What I'm going to be talking about here is valvular disorders, and particularly in relation to rheumatic fever, acute rheumatic fever that can develop into chronic rheumatic fever, and how that works. I know you can't really read what's on the board, but I'm going to explain it, so it'll be okay. All right, so acute rheumatic fever. Actually, I'll back up a little bit. Let's talk about some of these valves and kind of where we're going with this. All right, so right here, I'm going to draw an example of the heart. And right atrium, right atrium, left atrium, right ventricle, left ventricle. We have the vena cava draining into the right atrium. This is coming from the lungs. This down here is going to the lungs. And this down here is going through the aorta to the body. We have tricuspid valve here. We have the pulmonary valve there. We have the mitral valve here. We have the aortic valve there. And you can remember that by TP-MA. TP-MA. That works for you. So when you have stenosis, it means that there's like a narrowing of the valve, so not as much blood can get through. Okay, so if it's stenosed, typically what happens on stenosis is that it's harder for the blood to get pushed out, and so a lot of times what will happen is let's say you had stenosis right here on the right ventricle. What's going to happen is that your right ventricle, or excuse me, stenosis on your pulmonary valve, your right ventricle, in order to push all that blood out, is going to have to work really hard, and so you're going to get hypertrophy from it really having to strain, just like you were trying to use your muscle to push a lot of water through a tiny little hole. It's going to be really hard to do. So you get hypertrophy. Hypertrophy means the muscles get bigger, gets enlarged. So that's a lot of times what will happen in those cases. Sometimes you also have regurgitation. Regurgitation is where, so normally these valves, this is a bicuspid valve here. It's just two. Tricuspid would be a third one here. But so normally these valves, when they push, they go, and then they close like this, and they don't let any blood come back through. But in the case of regurgitation, it might be something like this. So it all goes, and then on the way back, it's not closed all the way. So it goes, and so what's happening here is that the blood is getting pushed out, and then something's going back again, and so it's getting pushed out, and something's going back again, or here, whatever. And your body, your heart has to work harder to get more blood out because it's just coming back in again. So you've got more pressure coming back in again. So a lot of times that can lead to hypertrophy as well. And those are going to have distinct sounds, on S1, S2, or those sorts of things. Okay, so now you kind of understand how that works. Talking about acute rheumatic fever. So this is the systemic complication of pharyngitis, group A beta hemolytic streptococci. In other words, group A beta hemolytic streptococci, you get infected with it, okay? And when you get infected with it, it's a complication that affects your whole system. But originally, group A beta hemolytic streptococci usually causes pharyngitis, strep throat, okay? Usually that's what it causes, but if you get a complication with it, with your whole system, it can be bad. So usually this affects children 2 to 3 weeks after their strep throat. So they get strep throat, and then 2 to 3 weeks later, they can get acute rheumatic fever. And this is how this happens. It's called molecular mimicry, okay? So that streptococcus, that microbe, the group A beta hemolytic streptococci, was really similar to, I guess particularly it's the protein M, resembles the protein M found in human tissues. Let me rephrase that. So here's human tissues. We have this protein M on our human tissues, and that sneaky, tricky group A beta hemolytic streptococci also developed a protein M. And so when our body went to attack when our immune system, our B cells, antibodies, T cells, whatever, I don't know exactly the details there, when they went to attack the group A beta hemolytic streptococci, they were targeting this guy right there, that M protein. But turns out that our body also has M protein, and so then our immune system starts attacking our own body. I think that's the way that it works. Maybe it's an immune disease. If not, I apologize, but that's what I got out of it. The other possibility was that it's mimicking your body, and so it doesn't kill it, so it's allowed to grow more. I'm not sure what the answer is exactly. Good thing to look up. Just now started questioning whether or not I understood that correctly. Okay, so that's what it's caused by. Is this group, this M protein that resembles human tissues. So how do you know if a person has acute rheumatic fever? They use something called the Jones criteria. So, and that is there's minor criteria and there's major criteria. Main thing, of course, is the person would have had to have had a prior group A beta strep infection. So if they never had a prior group A beta infection, then they're not going to have acute rheumatic fever. One of the minor things too is that they would have a fever and elevated ESR. So the major qualifications can be remembered using an acronym, Jones acronym. So J in Jones stands for joint problems, okay? Migratory polyarthritis. So J for Jones, joint problems. The O in Jones looks like a heart, kind of. Sort of looks like a heart, a little bit, right? So that stands for heart problems. So the O in Jones looks like a heart, stands for heart problems. Particularly pancarditis. Pancarditis means pan means all of it. Carditis means inflammation of the heart. So all of the inflammation of the whole heart. So that's going to be endocarditis, myocarditis, and pericarditis. All three of those are going to be inflamed. N in Jones stands for nodules on the skin. E in Jones stands for erythema marginatum. So what this means is you're going to have a red rash, and on the margin of the rash, erythema is redness, but it's going to be more pronounced on the margins of the rash. Okay? And then last, S was for symptoms chorea, which means, I guess, the movements, like choreatic movements. And yeah. Anyway, there you go. That's the Jones acronym. So, moving on to these heart problems, let's talk about this a little bit, because this is a discussion on cardiovascular issues. So with these heart problems, a person gets endocarditis of the mitral valve. Remember, there's valves inside the heart. That's the endocardium. So endocarditis, inflammation of the endocardium of the mitral valve. It's always the mitral valve first. Okay. So you've got these things. Remember, there's TPMA, tricuspid pulmonary, mitral, aortic. This mitral valve gets endocarditis on it. Okay, which means it gets where the little chorda tendineae attach on there. You get these little bulges of inflammation, and sometimes on top, after the mitral valve gets infected, sometimes also the aortic valve will become inflamed as well, and this can lead to regurgitation. So remember earlier, so imagine here's your valve, okay, that's normal. This thing gets all like inflamed and kind of warped. Look what's happening to it. Instead of like this, it's kind of like this, so it goes kind of sucks back. It's got that little hole in there. See that? So, and then this is kind of weird words here. They've got something called, so we just talked about the endocarditis. Now we're going to talk about myocarditis. There's some words here. I'll write them out for you so you can see, because they're odd words. I'll do it in black. It's a little easier to see the word. So it's something called Ashkoff bodies. ASHCOFF. Ashkoff bodies. So you're going to look at all the muscle cells, the cardium, and then you're going to see in there this little bulge of messy looking stuff, okay? And this little body, this little Ashkoff body, you're going to see some giant cells and fibroid type material like collagen and stuff like that. And also in there, you're going to see something called Anichkow cells. Let me write this out. Anichkow. Anitschkow. Anichkow cells. And these are like these cells that have this little caterpillar-looking nucleus. Kind of wavy-looking nucleus in the middle. It'll look like that. So you'll see those. That's typical, apparently, of it. And if there's anything that's going to kill somebody with acute rheumatic fever, it's going to be the myocarditis. It's going to be these Ashkoff bodies with these Anichkow cells, histiocytes or whatever they are. Okay, so that's acute rheumatic fever. Now, what about chronic rheumatic fever? So after a person has the acute rheumatic fever and it goes away, if they continue getting repeated exposure to group A beta hemolytic streptococci, this can lead to chronic rheumatic fever. In the case of chronic rheumatic fever, repeated inflammation and use leads to scarring, okay? And scarring can lead to stenosis. Kind of explain how that works. So, here's this valve, okay? And normally it's a nice big valve, but this thing gets all scarred and stuff and gets all huge, and it's going to be harder for it to let as much blood out. So it's going to go instead of, because all the scarring kind of makes it big and bulgy. Anyway, you know what I'm doing. So in this case, you're going to wonder, though, if the person has, sometimes people can get stenosis, aortic stenosis, just from wear and tear. The more that you use your heart, which you use it all the time, after a while, get some wear and tear, can get some scarring on there, and you can get stenosis naturally. So how would you know if the stenosis, let's say the person has aortic stenosis, and you want to know, was this aortic stenosis caused by chronic rheumatic fever, or was it caused by just wear and tear? So the first thing you have to say is there also mitral stenosis? Now, if there's also mitral stenosis, if there isn't mitral stenosis, then it's not rheumatic fever, because rheumatic fever always mitral valve first, then aortic valve. It's not one or the other. It's always mitral, then aortic. So if you want to know if it's wear and tear or rheumatic fever, and there's no mitral stenosis, then it's not rheumatic fever. Okay, so if there is, however, also mitral stenosis, then you could say it could be rheumatic fever. So how else would you tell? You could do these other tests. They have a number of them. You would have to, I can't remember what all what it was, darn it. I guess, that's right, you have to use the Jones criteria. Sorry, lost my train of thought there for a second. So you have to use the Jones criteria I discussed earlier. Okay, so the other thing that we have here is there's going to be, you got to know that there's going to be a prolonged symptoms, asymptomatic stage. So a person they'll get sick rheumatic fever, and they might have a long period of time, and then they'll get, later on the chronic version. Also, with some of these things, you'll hear a systolic ejection click followed by a crescendo and decrescendo murmur. So crescendo and decrescendo, basically like the sound, this is like a sound wave, it's going to decrease and increase, decrease and increase like that. That's like crescendo, decrescendo kind of thing. Left ventricular hypertrophy, that makes sense. Remember, if a person has stenosis of the aortic valve, then this left ventricle has to push really hard to get the blood through there, which means it's going to get hypertrophied. Also, with that, if there's not enough blood getting out, you can suffer from angina and syncope if the person exercises. And also, with all of the blood spitting out through there so fast, it can actually rupture some of the red blood cells. And that decreased amount of red blood cells, if it happens from that cause, and they call that microangiopathic hemolytic anemia. And when these symptoms start to present, the person is probably going to need to have a valve replacement.